I am Dr. Kevin Cavanaugh, Chairman of HealthWatch USA, and today I would like to welcome Dr. Hrdlicka, who will be speaking to us regarding pathophysiology and presentation of lingering COVID-19, in other words, long haulers syndrome. He is the research coordinator of the Milne Institute for Healthcare Innovation at Gaylord Specialty Healthcare, and I think this is going to be an excellent and informative presentation. So Dr. Hrdlicka, I'll turn the floor over to you and thank you.
You're welcome. Thank you so much for that lovely introduction, Kevin. Again, my name is Henry Hrdlicka, and I am the research coordinator of the Milne Institute for Healthcare Innovation at Gaylord Specialty Healthcare. To start, I would like to tell you about Gaylord Specialty Healthcare. We are a rehabilitation-focused nonprofit healthcare system. Gaylord is anchored by Gaylord Hospital, a long-term acute care hospital located in Wallingford, Connecticut, and we provide inpatient and outpatient care at multiple locations within Connecticut, and we are one of few organizations accredited by both the Joint Commission and the Commission on Accreditation in Rehabilitation Facilities, or CARF. We are widely recognized for treating patients with spinal cord and traumatic brain injuries, pulmonary, cardiac, amputee, stroke, and other medically complex conditions, including acute and post-acute COVID-19. Severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, as many of us know, is a novel beta coronavirus strain first observed in Wuhan, China in late 2019. SARS-CoV-2 presents in one of two ways, either asymptomatically or as coronavirus disease 2019 or COVID-19. COVID-19 symptoms can range from mild upper airway symptoms to COVID-19 pneumonia, also known as acute respiratory distress syndrome, or ARDS. ARDS oftentimes corresponds to respiratory failure and a high fatality rate. Back on March 19, 2020, Gaylord Hospital admitted its first patient with COVID-19 for acute care and rehabilitation. Now, Gaylord's experiences with the first wave have been summarized in a white paper on our website titled Patient Outcomes and Lessons Learned from Treating Patients with Severe COVID-19 at an LTAC Hospital. And I want to go through some of these results to kind of give you some background in our experience and what we have been seeing since the start. So for our study, we compared the outcomes of our first 117 COVID-19 patients to a reference cohort of 170 patients treated the 3 months before the start of the pandemic. Now, looking at Gaylord's first COVID-19 patients, we saw that compared to the reference cohort, COVID-19 patients were younger, 63.3 years versus 65.6 years of age. They had a higher BMI, 30.3 versus 27.4, and many of our patients were working leading up to their diagnosis. In fact, several of our patients were healthcare workers. In our COVID population, we also saw that there was a higher proportion of non-white demographics, and that our COVID-19 patients had a similar length of stay to our reference cohort. Within these 117 patients, 51 COVID-19 patients were admitted as fully dependent or non-ambulatory. By discharge, 40 of the 51 patients were ambulatory to some level, and this was assessed using a modified functional independence measure shown, and the scale here is showing these outcomes. Within the COVID-19 patients, gait distance increased an average of 217.4 feet during their stay, compared to 146.3 feet in the reference cohort. This increase in gait distance by discharge possibly is a reflection of the COVID-19 cohort's age and health prior to illness. Of the 16 patients who were mechanically ventilated at admission, 15 out of the 16 were weaned before discharge. Now, this 93.8% mechanical ventilation wean rate was much higher than our typical rate, which was 76% in all of fiscal year 2020. And the average wean time of the COVID-19 cohort was 11.3 days, which was similar to both the reference cohort and all of our mechanical ventilation patients in fiscal year 2019. Of the 75 patients that were assessed by speech-language pathology, also known as speech therapy, 31 of the 75 displayed some form of cognitive deficit, including attention span, processing speed, short-term memory, and working memory. At discharge, 16 of the 75 had only mild residual deficits, while 5 out of the 75 had continuing moderate to severe deficits. Many of these patients were discharged with recommendations for continued outpatient therapy. In conclusion of this study, we found that many patients benefited from coordinated care and rehabilitation. And the majority of these patients treated for severe COVID-19 and the related complications showed significant improvement, including in their functional ability, respiratory measures, cognitive communication, and other measures that I didn't have time to discuss today. Together, this data suggests that the patients in the post-acute phase of COVID-19 benefit from some sort of structured rehabilitation. However, many COVID-19 patients never required or sought hospitalization and did not receive structured rehabilitation such as this. And the majority of these patients have recovered just fine. However, a subset of patients who never sought medical care before, and even some of those who did, have reported lingering COVID-19 symptoms. These patients have widely become described as COVID-19 long haulers. And as more becomes known and publicized, increasing number of patients are seeking outpatient occupational, physical, and speech therapy for their symptoms. And at Gaylord, we have begun seeing many of these patients. Now you may ask, what do COVID-19 long haulers look like? And you may be asking, what do COVID-19 long haulers experience? Well, each patient differs, but some of the most common and ubiquitous symptoms that our outpatient clinics have observed include persistent fatigue and general malaise, or general sense of unwellness, generalized weakness, exercise-induced shortness of breath, poor exercise tolerances paired with cardiac challenges, and cognitive difficulties. And these lingering cognitive difficulties are often referred to as brain fog, both in long hauler community and the media. Symptoms which are less frequently observed but are still present include things such as persistent blurry vision, double vision, depth perception problems, light sensitivity, and dizziness. And one thing that we have to take into account are, in addition to these physical symptoms, are the psychological difficulties that these patients are facing. Some of these patients have experienced true trauma. And as such, we have observed many patients who present with various psychological difficulties, including anxiety, depression, and PTSD. And PTSD has been especially common when these individuals need to return to the same work environment where they contracted COVID-19 initially. And now we need to ask, how do we begin to address these symptoms and help these patients move forward? And as with any problem, the first step is understanding how COVID-19 impacts the different bodily systems. And this is a very complex disease. And in addition to the direct viral toxicity of COVID-19, the strong immune response, which is elicited, oftentimes referred to as the cytokine storm, can lead to many off-target effects and may prompt the body to start to attack itself when it normally wouldn't. Now, the most frequently reported bodily systems impaired by COVID-19 include neuropsychiatric, hematological or blood, renal or kidneys, respiratory, lungs, cardiac, also known as the heart, and the musculoskeletal and gastrointestinal systems. Now, I want to walk through and discuss what symptoms are seen in each of these bodily systems. First, looking at the neuropsychiatric impairments, It's currently unclear which neuropsychiatric impairments are a result of viral toxicity and which are related to the trauma that these patients have experienced. And in a recent study of 179 COVID-19 survivors 2 months after discharge, it was found that over half of these patients presented with moderative neurocognitive impairments and 18% presented with severe neurocognitive impairments. And these impairments included things such as verbal memory issues, verbal learning, verbal fluency, and working memory. And many of these patients in this study also presented with anxiety, depression, and PTSD. And we have observed many of these symptoms in our outpatient and inpatient settings. In regards to hematological or blood impairments, in COVID-19 patients, it's been found that they are experiencing what is known as a hypercoagulable state. Now, in this state, the blood gets thickened. You can think of the blood getting thicker and leading to an increased risk of blood clots. And this has been observed in many patients. This increases the risk of stroke, pulmonary embolism, which is a blood clot in the lungs, and deep vein thrombosis, which is a blood clot in, say, your arm or leg, and it's going to elicit a lot of pain, and other blood clots that I'll be talking about soon. Now, the current theory is that COVID-19 causes some sort of endothelial injury in the highly vascularized organs, including lungs, kidney, and heart, and this leads to excessive production of blood clotting factors, such as D-dimer or thrombin. And now, the growing prophylactic use of anti-clotting medication or anticoagulants, there have been increased incidences of pulmonary embolism, deep vein thrombosis, and stroke continuing to be reported in many COVID-19 patients. Now, looking at the renal system, The hypercoagulable state caused by COVID-19 can cause blood clots in the kidneys, and this leads to a decrease in the oxygen available to the kidneys and can cause them to malfunction and to start to have damage. Signs of kidney problems in patients with COVID-19 include high levels of protein in the urine, also called proteinuria, abnormal blood work, and in some cases, kidney damage has been so severe that the patient required dialysis. Looking at the cardiac systems of the heart, this excessive inflammation caused by the immune response and by COVID-19 can lead to scarring of the heart, and this has been reported in many COVID-19 patients. In a recent study of 148 patients, 54% of the patients hospitalized with severe COVID-19 had heart damage due to increased troponin. Troponin is a protein that is a byproduct of the heart. Now, 26% of these patients displayed severe scarring of the heart, while 22% presented with a heart attack, and 6% of the patients displayed both impairments. Looking at the respiratory system or the lungs, shortness of breath and chest pain have been shown to be dominant respiratory COVID-19 symptoms. And acute respiratory distress syndrome, which I talked about earlier, is the major respiratory complication in severe cases of COVID-19. And the patient's condition and recovery can also be complicated by the presence of pulmonary embolisms or blood clots due to the hypercoagulable state. Now, an interesting thing to mention is that as the pandemic has progressed, clinicians have altered their approach to treating pulmonary impairments, where in the beginning of the pandemic, they were quick to intubate and quick to put patients onto mechanical ventilation. Intubation and mechanical ventilation are now held off for as long as possible. And this has been shown to increase the patient outcomes. What we're seeing in the musculoskeletal system is that fatigue and malaise is the most commonly reported symptoms. And these symptoms may last for weeks to months. And in some cases, we've been seeing reports of these symptoms lasting up to a year, the length and duration of the pandemic. Now, muscle and joint pain are also frequently reported, and muscle pain is present in 15% of COVID-19 patients. And osteopenia, the loss of bone mineral density, and osteonecrosis have also been observed in isolated COVID-19 patients. Now, there's not enough data to know if this was caused directly from the viral toxicity itself or if it was from extended bed rest. It's well known in the literature and in practice that extended bed rest can also lead to osteopenia, the loss of bone mineral density. So that's something that unfortunately, we'll need more data to figure out going forward. And lastly, looking at the gastrointestinal system. GI symptoms associated with COVID-19 include many things, including the loss of taste and smell, vomiting, nausea, anorexia, and diarrhea. In one recent study of 116 patients with COVID-19, 32% experienced gastrointestinal symptoms, including 22% reporting nausea, vomiting, and loss of appetite, and 12% having diarrhea. In conclusion, COVID-19 affects nearly all bodily systems, and this causes some patients to have devastating side effects. And to improve the care and rehabilitation of COVID-19 patients and long haulers, a lot of work still needs to be done. And only by continuing to learn and understand the long-term effects of severe COVID-19 will we be able to address all of the impairments that we talked about today and those that we have yet to experience. And with that, I'd like to thank you all for your attention and would be happy to take any questions